Good morning. Am I audible? Good morning. Am I audible?
Yes, ma'am.
Yes,
Yes,
ma'am.
ma'am. Yes.
Okay. So yesterday we have started with vitiligo, also called as leukoderma. We will revise in short yesterday's part. You can see the image of vitiligo histopathology. The absence of melanin at the site of white patches. We have seen what is melanocytes and melanin. Melanocytes are special cells in our skin that specialize in making a molecule called melanin. And melanin is something called a pigment, which is the molecule that gives our skin color, which is a darker shade. What does melanin actually do? Melanin protects our skin from damaging ultraviolet rays from the sun. It also causes sun tanning. Melanogenesis, first there is a formation of melanoblast, then melanocytes, and after that melanin. In this process, phenylalanine converts to tyrosine, and the color of the rays is depending on the rate of melanin production. This is the melanin life cycle. First is melanocyte activation due to sun exposure, inflammation, pregnancy, aging. This melanocyte activation leads to formation and maturation of melanosomes, which again leads to melanin production, that is tyrosine mediated synthesis of melanin. And after that, this melanin is distributed throughout the skin. And after that, melanin removal by exfoliation of melanin containing keratinocytes. We have seen this. The fact that the origin of word vitiligo, that is, it is originated from the words vitium or vitellius. It can appear at any age, usually first appears between age of 20 and 30. White patches may begin on your face, above your eyes, on the neck, armpits, elbows, genitals, hands or knees. 1 to 200 of the world population develops the vitiligo, and it affects both genders and all races equally. You have seen this. It is the chronic skin disease. Other name is leukoderma. White spots occur when the skin no longer forms melanin, and the white patches of irregular shapes begin to appear on skin. Any part of the body may be affected. Common sites are exposed areas like face, neck, eyes, nostrils, and another areas like nipples, navels, genitalia, body folds like armpits and groin, sites of injury, cuts, scrapes, burn, and around the pigmented moles. The patch which is around the pigmented moles, it is called as halo nevi. You can see in the image, this spot is called as halo nevi. Symptoms and signs: white patches of skin, whitening or graying of the hairs on scalp, eyelashes, eyebrows, or beard. The segmental white patching or segmental graying of hair is called as leukotrichia. You can see in the second image, segmental graying of the hair called as leukotrichia. Then this degree of pigment loss can vary within each vitiligo patch, which means that there may be different shades of brown color in vitiligo patch, called as trichrome. See in the image, mainly third image, the trichrome vitiligo, the localized chalky white discoloration with pigmentary interface between normal and depigmented areas. It is called as trichrome vitiligo. Symptoms: white spots that develop into white patches of skin that looks different from the rest of the skin. Initial size of the patch can be as small as dot that can grow larger to form a large sized patch. And initial appearance of the patches is slightly pale that along with time grows whiter and whiter because of loss of melanin pigment from the skin. These are the types, mainly two types, localized and generalized. In localized, focal vitiligo, segmental vitiligo, and mucosal vitiligo. In generalized type, acrofacial, vulgaris, universal, and mixed type. Yes, in focal, one or more macules with casual distribution. It may be unilateral, means only one side of the body is affected. Mucosal, unique involvement of mucous membranes. Vulgaris means presence of scattered stains extensively disseminated. Acrofacialis, mainly patches are on the distal extremities and face. And mixed, coexistence of acrofacialis and vulgaris. And universalis, depigmented lesions completely or almost completely, which covers the skin surface. More than 80% of the body surface is involved. Then these are the common sites. It can be associated with premature graying of hairs in relatives. There may be history of Cobner's phenomena. What is Cobner's phenomena? That is history of injury at the site of patch. And that injury is developed into the patch. So it is positive Cobner phenomena. There may be history of emotional or physical stress. Drugs like chloroquine or clofazimine. Then systemic association. There may be increased risk of autoimmune diseases like thyroid disease, Addison disease, pernicious anemia, insulin-dependent diabetes, and alopecia areata. Then there can be some eye disorders like uveitis and depigmentation of choroid. Ear disorders like auditory problems can occur. Psychological impact of vitiligo, that is feeling of stress, embarrassment, and self-consciousness. Perception of discrimination, low self-esteem, disturbed sexual relationships. Then there are some theories according to their etiology, like familial theory, autoimmune theory, autocytotoxic theory, neural theory, and self-destruction theory. In familial theory, there is a positive history of vitiligo in family members. Autoimmune therapy, that is antibodies forms against melanocyte surface antigens and that destroy our melanocytes. Then autocytotoxic, increased melanocyte activity leads to its own demise. Here is the inhibition of thyroredoxin reductase by calcium. Mainly higher calcium levels cause increased superoxide radical formation. Neural theory, that is patients with nerve injury and vitiligo in denervated areas. Clinical evidence of segmental dermatomal vitiligo. Can be history of increased sweating and vasoconstriction in vitiliginous areas. We have seen this self-destruction theory. It suggests that melanocytes are destroyed by flaws in the protective mechanism that removes the chemical toxin that is generated in melanogenesis. These are molecular changes. All these factors like antibodies against melanocyte antigen, environmental triggers and stressors, T cell activation, imbalance of epidermal cytokines, oxidant stress and oxidant antioxidant imbalance, melanocyte detachment, decreased melanocyte growth factor, defect in calcium uptake in keratinocytes and melanocytes, and decreased zinc alpha 2 glycoprotein. All this leads to vitiligo in genetically predisposed patients. In medical screening, we can get family history of vitiligo. We should look that if there is a rash, sunburn, or other skin trauma that has occurred within 2 or 3 months after pigmentation was discovered. There may be premature graying of hair before age 35. Also, there can be, we can ask them for eye examination and a blood test for autoimmune diseases. Histopathology, it shows uniform absence of melanocytes. Periphery of depigmented patch shows signs of cellular death. Dilatation of rough endoplasmic reticulum in melanocytes and inflammatory changes in dermis. Then evaluation, total body wood slides examination. That is, we should look all over the body, all areas for the patches, TSH levels, CBC, evaluation about diabetes mellitus, ophthalmological examination. Then treatment. We are seeing this treatment, that is cosmetic treatment, PUA. PUA includes topical and systemic, corticosteroid, surgical treatment, and monobenzoyl ether hydroquinone. In cosmetic treatment, there are number of cosmetics present to cover the marks like cover mark, derma blend, derma color, etc. Then some topical dyes, Clinic Bonds Gel, Vitadye, Diodome, tanning creams like Chromalin, self-tanning milk, etc. Advantages, their cost is very less, ease of application, lack of side effects. But there are some disadvantages. In vigorous physical activities, these creams cannot work. And in extensive diseases, when there is a generalized vitiligo, we cannot apply the cosmetics all over body. Then PUA treatment, that is Soralen plus UV ultraviolet radiations. So this ultraviolet or light therapy in combination with Soralen started in 1948 at Almofte. How it acts? It causes immunological mediated action. It stimulates the tyrosinase activity. There is an inhibition of DNA and protein synthesis, depletion of ECF expression, depletion of vitiligo-associated melanocyte antigens. It causes melanocyte repigmentation. How? This causes activation of inactive cells, which are spared in vitiligo process, in the middle and lower part of the follicle and in outer sheath. These inactive cells contain structural and melanosomal proteins, but do not contain enzymes required for melanogenesis. Migration of melanocyte from lower hair follicle to epidermis depends on cytokine release and inflammatory mediators. Then today we'll start with topical Soralens. Patients with less than 20% of total body surface, Soralen is applied to the patients with less than 20% of total body surface. Initially, 0.05% or 0.1% strength should be used. Then artificial ultraviolet A source for 30 seconds initially, and increasing exposure to up to 10 minutes 2 to 3 times per week. At 10 minutes, higher strength, that is 0.1% to 0.15% should be prescribed. Shielding uninvolved skin and eyes. Wash off the topical solution immediately after treatment. So what happens actually in this treatment? The psoralen is applied and then ultraviolet A radiations are exposed. Here, shielding should be done of uninvolved skin and eyes. That should be covered. Sunblocks, avoiding direct and filtered sunlight for the rest of the day. There are some side effects like blistering, burning, and perilesional hyperpigmentation. This is the most effective treatment available. This PUA therapy is to repigment the white patches. This is the compartment in which PUA therapy is done. It is time consuming and care must be taken to avoid side effects. Psoralen is a drug that contains chemicals that react with ultraviolet light to cause darkening of the skin. Sometimes psoralen is injected orally or is applied to the skin. It is available in both forms, injectable and local application. Then skin is carefully timed exposure to sunlight or to ultraviolet A light that comes from a special lamp. Then second treatment is oral psoralen or UVA. It is useful in patients with extensive lesions. 0.5 mg per kg 2 hours before treatment, oral psoralen is given. Started at 1 to 2 J per centimeter square of light 2 to 3 times a week. Darker pigmented patients and children responds better to PUA. Then trunk, proximal extremities and face responds better to PUA. Distal extremities, periofacial and dermatomal lesions do not respond better. Here are also some side effects like burns, nausea, erythema, pruritus, xerosis, fatigue, carcinogenicity, pigmentations, cataract, and aging. It is contraindicated in pregnant women, breastfeeding, history of skin cancer, arsenic exposure, photosensitivity, radiotherapy, and cataract. This PUA therapy is contraindicated in pregnant women, breastfeeding, history of skin cancer, arsenic exposure, photosensitivity, radiotherapy, and cataracts. And after therapy, it is advised to visit ophthalmologist yearly, wear goggles, avoid direct and filtered sunlight for 24 hours after treatment. Then second type of therapy is corticosteroids. Corticosteroids first used in 1959 by Japanese. So corticosteroid therapy first started in 1959 by Japanese. It can be both both systemic and oral. It is used for localized depigmented patches. High potency steroids for 1 to 2 months. And these are slowly tapered to lower strength. And it has usual side effects. So corticosteroids first used in 1959 by Japanese. Both type of corticosteroids are given systemic and oral. Localized depigmented patches. High potency steroids for 1 to 2 months. And this corticosteroid slowly tapered to lower strength and it has usual side effects. Then topical steroid therapy. The use of steroid creams may be helpful in returning the color to the white patches. A mild topical corticosteroid cream for children under 10 years old and a stronger one for adults. Cream must be applied to the white patches on the skin for at least 3 months before seeing any results. These corticosteroid creams are the simplest and safest treatment for vitiligo, but are not as effective as soral and photochemotherapy. Side effects. Side effects can occur in areas where the skin is thin, such as on the face, armpits, or in the genital region. And they can be minimized by using weaker formulation of steroid creams in these areas. So topical steroid therapy, it is the use of steroid creams which may be helpful in returning the color to white patches. A mild topical corticosteroid cream for children under 10 years of age and stronger one for adults. Cream must be applied to the white patches on the skin for at least 3 months before seeing any results. Corticosteroid creams are the simplest and safer treatment for vitiligo, but are not effective as soral and phototherapy. Side effects occurs in areas where the skin is thin, such as the face, armpits, or in the genital region. The next one is surgical modalities, like localized non-progressive patch in a non-acral location, epidermal grafting, autologous mini grafting, transplantation of in vitro cultured epidermis, transplantation of non-cultured melanocytes. So these are surgical treatments. First one is epidermal grafting. The blisters at donor and recipient sites by suction or liquid nitrogen. This roof of the blister is removed from both sides and donor epidermis is placed on denuded recipient site. Reinforcement with biological dressing. Repigmentation seen in 2 weeks to 3 months. Pre-treating donor site with topical PUA to stimulate melanogenesis, and it may enhance repigmentation. And in epidermal grafting, there are low incidence of scarring. Then autologous mini grafting. If there are multiple small punch biopsy specimens at inconspicuous donor site close together, at recipient site, it is separated by 4 to 5 mm. Test the area which is chosen and 3 to 5 mini grafts are placed to determine the ability. And after 2 months, if the pigment has spread, grafting of the entire region is continued. Then in vitro cultured epidermis, same like first one, blisters at both donor and recipient sites. Epidermis from donor site is treated with trypsin. Melanocyte is isolated and grown in the cell culture for 3 weeks. Then melanocytes adhere to Vaseline gauze, which is divided and placed over the denuded recipient site. And with this procedure, repigmented site can be as large as 10 times to the donor site. There are some pitfalls of this technique. First is variegated color due to variable melanocytes concentration on the gauze and spotty graft failure. The next is non-cultured melanocytes. Non-cultured melanocytes obtained with dermatome from the donor site. Melanocytes treated with trypsin, EDTA, and placed in a saline solution. And it is injected as a suspension into the blisters in the recipient site, which is created by liquid nitrogen. So in these cases, repigmentation is faster than in vitro melanocytes. Then hydroquinones. It is used in extensive disease where remaining normal skin is depigmented. Inhibits the tyrosinase, decrease the number of melanized melanosomes. It alters the melanosomal configuration and causes melanocytes organelle disruption and lysis. A result may take from 1 month to 1 year to depigment completely. Means here, by use of hydroquinones, the repigmentation is not occurring. The other skin which is not involved, it is depigmented. Then prognosis of vitiligo. So vitiligo frequently begins with a rapid loss of pigment, which may be followed by lengthy period when the skin color does not change. Later, the pigment loss may begin again after treatment also. The loss of color may continue until for unknown reasons and the process stops by its own also. Cycles of pigment loss followed by periods of stability may continue indefinitely. So we cannot say vitiligo is completely curable because the pigment loss may begin again. So what is the homeopathic treatment for vitiligo? Homeopathy offers proven treatment for the cases of vitiligo which do not have extensive spread. Early and milder cases may be treated with excellent success. Moderate and spreading cases can expect partial color formation with good control, while rapidly spreading cases may be controlled significantly. It may be noted that good control over the spread is also considered a success in extensive cases. As we know, it is not completely curable. So we can treat partially or we can stop the spread of vitiligo patches. The homeopathic treatment works in the following manner, like controlling the spread of vitiligo by attempting to correct the immune system, enhancing the natural melanocyte formation, that is melanogenesis. So what does homeopathy treatment do? The scientific and documented study shows that homeopathic treatment helps to achieve. It enhances melanocyte formation by stimulating natural process called melanogenesis. So our medicine can stimulate the natural process of formation of melanocytes, that is melanogenesis. It controls genetic disposition by using miasmatic medicines. It treats after effects of environmental factors such as exposure to chemicals. It can treat after effects of emotional stress, which may have triggered the disease process of vitiligo. It corrects the hormonal imbalance, such as underactive thyroid, that is hypothyroidism, helps body cope up with stress and emotional pressure, individualistic approach whereby every patient is treated based on the one's case. Miasmatic diagnosis of vitiligo. The complete absence or diminution of melanocytes from the birth is due to syphilitic miasm and cure by antisyphilitic medicine. Case with the function of melanocytes is defective. It represents psychotic miasm. Secondary depigmentation during the cause of illness due to SORA, psychosis, and syphilis, or a combination of 2 or 3 miasms. So, miasmatic diagnosis mainly if the complete absence or diminution of melanocytes is from birth, so it is due to syphilitic miasm. So, in that case, we should use antisyphilitic medicine. Case with the function of melanocyte is defective, it represents psychotic miasm. Secondary depigmentation during the cause of illness is due to SORA, psychosis, or syphilis, or due to combination of these 3 miasms. Then repertorial approach. Vitiligo-related rubrics are present in various commonly used repertories, which serves as guide for the selection of best similar. There are some rubrics like skin discoloration white. Medicines are Epis, arsenic, calcarea, cargovage, floric acid, Kalika, black can. So repertory in it is found in synthesis repertory. Skin These are the rubrics which are found in repertories like skin discoloration white spots. In Kent repertory, skin discoloration white. In Murphy repertory, directly skin vitiligo. Then skin and exterior body spots white in BBCR. As we know, vitiligo is an autoimmune disease. It is the external expression on the skin due to internal dysfunction at the level of immune system. Homeopathic medicines are selected on the basis of individualistic approach. After the case taking in every case of vitiligo, which is based on affected area of vitiligo, spread of vitiligo, emotional, past history, family history, etc. There is no single specific remedy for all cases of vitiligo. Homeopathic medicine controls the spread of vitiligo by stimulating the skin pigments to generate melanin and help to regain the normal skin color. So some remedies like arsenic album, there is itching, burning, swelling, edema, eruption, papular, dry rough scaly skin, worse by cold and scratching, worse in wet weather after midnight, and better from heat. Arsenic sulphuratum flavum, skin mainly chapped about genitals, leukoderma and squamous syphilis, it covers calcarea carp, unhealthy skin, readily ulcerating, flaccid skin, small wounds do not heal readily, glands are swollen, natal rash better in cold air. With vitiligo, there may be warts on face and hands, petechial eruptions may be present, also chilblains and boils may be present. Then crotalis horridus, swelling and discoloration, skin is tense and shows every tint of color with excruciating pain. Used in vesication, sallow yellow color of whole body, great sensitiveness of skin of right half of the body, hydrocotyle ascitica, dry eruptions, great thickening of epidermal layer and exfoliation of scales. Patches are with circular spots with scaly edges, with intolerable itching, especially soles, with profuse sweat, syphilitic affection, also used in acne, leprosy, elephantiasis, lupus, lachesis mutus, Hot perspiration, bluish purplish appearance of dark blisters, used in bed sores with black edges. Blue-black swellings, used in pyoemia or dissecting wounds. Magnesium carb, earthy, sallow and parchment-like patches. Emaciation is present. Itching of vesicles on hands and fingers. Nodosities under skin is formed. Sore and sensitive to cold. Natrum muriaticum, greasy oily skin, especially on hairy parts. Dry eruptions, especially over margin of hairy scalp and bends of joints. Crusty eruptions in bends of limbs, margin of scalp. Then sulfur. Dry, scaly, unhealthy skin, every little injury suppurates, freckles, itching, burning, worse by scratching and washing, pimply eruptions, pustules, raggeds, hangnails, excoriation, especially in folds, feeling of band around bones, skin affections after local medications, pruritus, especially from warmth in evening. It often recurs in springtime and damp weather. We'll see one case. We'll see one case of vitiligo treated with homeopathy. Name is Miss PD, 10 years old, female. There is a white discoloration of skin on the anterior part of the neck since 6 months. So just starting of the patches. White discoloration of skin on the anterior part of the neck since 6 months. The patient was apparently alright 6 months back. Then she noticed a small white patch on the anterior part of the neck. Gradually, the size started increasing in 3 to 4 months. The patch is increased about 3 to 4 centimeter in size and also appeared on right flank over bilateral knee joints. So she took some Ayurvedic treatment for the same but had no relief. There is no history of itching, pain, burning, loss of sensation at affected part, no history of local trauma, long-term medications, radiation, infection, or contact with chemical agents. You can see this is the patch on neck, on trunk region, on the knees. These white patches are since 6 months. There is no specific past history. In family history, mother is psoriasis, hypothyroidism, father is DM, paternal grandmother, diabetes and hypertension. There is no history of vitiligo in the family. Personal history, it is also normal. Especially there is a desire for sweet 2 plus, milk plus. Patient was thirsty, chilly. Perspiration is profuse all over, especially palms and soles. Pediatric history, it is FT child. All milestones are normal and in time. No any adverse reaction after any vaccine. Mentals, she is calm. Takes time to mix up in people. So she is introvert. Fear of being alone. Wants someone always. She is very obstinate and having anticipatory anxiety. All things are normal. Inspection of the skin. Site is anterior part of the neck, about 3 to 4 centimeter patch. Right flank, approximately 2 centimeter. Right knee, approximately 1 centimeter, and left knee, approximately 0.5 centimeter. Depigmented, milky white, oval shaped patches, which are well demarcated. Palpation, no tenderness present, no loss of sensation at affected site. This is very important to rule out leprosy. In leprosy, there are also initially only white patches, but these white patches are having loss of sensation. So we should do pinprick test. So in leprosy, there is a loss of sensation, and in vitiligo, their sensation is intact. So no loss of sensation in this patient. Local rise of temperature is absent. Systemic examination was normal. Investigation advised is skin biopsy SOS. Differential diagnosis, vitiligo and pityriasis alba. And provisional is vitiligo. Miasmatic cleavage. In SORA, it covers anticipatory anxiety. Thirsty patient desires sweet. In psychosis, obstinate, calm, introvert, fear of being alone, profuse perspiration, family history of hypothyroidism, DM, hypertension. Syphilis, it causes white discoloration of the skin, and vitiligo. Analysis of case, type of disease is chronic, phase of disease is structural, Hahnemannian classification is dynamic chronic disease, miasmatic, fully developed psychosyphilitic. Incurability, as we know, it is incurable. So it is analyzed. Evaluation, symptoms taken are fear of being alone, want someone always, obstinate, anticipatory anxiety, desire sweet, perspiration profuse, all over, especially palms and soles, calm, introvert, desire milk, thirsty, and white discoloration of skin. So these are rubrics taken. And this is repertory sheet. So after repertorizing, the close coming remedies are silicia, calcarea, and phosphorus. So the remedy given is silicia 1 ml, single dose, and SL for HS. So silicia was given on 16th 2018. On 27, brown pigmentation started on the patch over neck and no any new patch. On 6/4/2018, the silicia 10 was repeated. As we know, the action of silicia is for some 30 days. So silicia 10 was given. You can see the images. 16/3/18, silicia was given. 21/3, the pigmentation, brown pigmentation was started. Then on 27/3/18 and on 6/4/18, you can see the repigmentation is started. So we can say the partial cure is started. Auxiliary, take proper diet, that is take more fruits and vegetables and avoid exposure to sunlight. So this was short case. So thank you. If any doubt, you can call me or message me personally. Thank you. You can leave the meeting.